Hello, my name is Kassandra Romas and welcome to 30 Medical Minutes. Our topic today are cancers of the head and neck. Cancers in this area are becoming more common with patients suffering uncomfortable and long-lasting effects if not treated early enough. Our guest, Dr. Tom Thomas, is an otolaryngologist, subspecializing in head and neck cancers and surgery. He is affiliated with Atlantic Health System and is the director of the Head and Neck Reconstructive and Transoral Robotic Surgery Department. He's going to discuss the different types of head and neck cancers, the causes and symptoms, and he will outline the different types of treatment options. Please stay tuned for this very interesting show. And now let's welcome Dr. Thomas to 30 Medical Minutes. Once again, welcome Dr. Thomas to 30 Medical Minutes.
Thank you, Cassandra. It's great to be here. It is an opportunity for me to educate our community about head and neck cancers that doesn't get a lot of attention. So this is a great opportunity.
That's wonderful. I once again appreciate your joining us. So why don't you tell us a little bit about yourself, your specialty, and what you do?
I'm an otolaryngologist by training. It's a long word for ear, nose, and throat specialist.
Okay.
And I have done head and neck cancer surgery fellowship after that. So I did my residency at Washington University in St. Louis, completed after 5 years, then came back to Penn to do my head and neck cancer surgery fellowship, where I learned how to exclusively take care of head and neck cancer patients, then learned the technique of transoral robotic surgery and microvascular surgery. Then I took my first job at Harvard in Boston 5 years ago. I was there as the associate director and recently joined Morristown Medical Center Cancer Center to bring up this head and neck cancer at comprehensive care to Morristown and the rest of New Jersey.
Well, thank you very much. I know that the entire Atlantic Health System is very grateful that you're here and enhancing the whole department. So our topic today are head and neck cancers. Why don't you start us off by telling us what does that entail? Where in the anatomy is this? What does it encompass?
Head and neck cancers are a diverse group of uncommon cancers that you see from the vertex of the scalp all the way to the clavicles or the upper chest. So it includes skin cancers, it could include thyroid cancers, and all the other cancers that can affect the head and neck. I have brought some models
yes,
to
why don't you show you. Show our
this is a model that I use to explain to my patients about some of the cancer sites people can get. Let me use this pointer. Cancers of the jaw, tongue, back of the throat. You can see thyroid glands. Right here is the voice box where you get cancers from smoking. This is the Adam's apple. Males and females get it. And this is your windpipe or the trachea. And this is a bigger model that is showing how the thyroid gland is situated right next to the windpipe or the trachea and the larynx, which is the Adam's apple. And I will show you another model where we take care of cancers of the nasal cavity and sinuses, which is the model here. Mm-hmm. That is showing different types of sinus cavities and nose, back of the nose, and the pituitary gland here, etc.
Okay. If you think about it, Dr. Thomas, this is a very small area of the body that we're talking about, but it seems like it's very intensive with the amount of organs and functioning areas. I suppose you would call them organs. Yeah. That you have to oversee. And right. Because they're so intense, there's a lot of possibilities of the cancers invading. Is that correct?
Absolutely. So American Cancer Society predicts there is about 63,000 head and neck cancers will be diagnosed in this country in 2017. And at least anywhere from 12 to 13,000 patients will die of this cancer. This does not include cancers of the thyroid, which is another 56 to 58,000 people. Plus, also, it doesn't include the skin cancers that are involved in the head and neck region, especially melanoma. More than 10% happens in the head and neck region. So, and like you described, each of these organs are important. One for function, obviously, and also it's part of your identity. Your face, your head is your identity, how you look. So treating the cancer can sometimes disfigure the person in terms of cosmesis, or if we don't do the right surgery or right treatment, even with the right treatment, the function such as breathing, swallowing, tasting, hearing, seeing, all can be affected. Mm-hmm. So that's why it's a very complex area that need a team approach to diagnosing, treating, and aftercare. I can be a great surgeon and do a great surgery and remove the cancer, but how are we going to deal with that patient afterwards? Mm-hmm. So by doing surgery alone is not good enough. We need to be able to work in a multidisciplinary setting in terms of radiation or chemotherapy. And then once all the treatment is done, we have to work with speech therapists and social workers and nutritionists to get that patient back to their normal life.
Right. So you've described a lot of different cancers here, all in the area. You've mentioned tongue and mouth and lips and throat and voice box, thyroid. Did you mention pituitary? That's not in your area, though.
Right. So the pituitary is usually done by neurosurgeons, but the otolaryngologists create the approach. There's a transnasal approach. It's a minimally invasive approach that you can get to the pituitary through the nose, through the sphenoid sinus into the pituitary. So we opens up the area for the neurosurgeons. So neurosurgeons can go in, remove, and then close it. So it's a teamwork.
Okay, obviously an incredible team approach, and it's amazing you can do that. Now, when we're talking about cancers, are we talking about tumors where you can go in and remove it? Since you say you're a surgeon, do you go in and you snip out what is growing there that is not benign? Right.
So I do benign and cancer surgeries.
Okay.
So depending on the size and the location and what is involved, yes, surgery is one of the ways to cure head and neck cancers.
Okay.
So if that is small enough, yes, you can go in there, remove it, and it heals, and you're essentially done.
Okay. Well, then hopefully if somebody has some sort of a tumor or a cyst, I suppose, if it's non-cancerous, you can go and remove it. But what if it has become a cancerous type of situation? What types are there besides tumors?
Right. So tumors are just a kind of controlled growth or a lump. So it's just a bucket term, essentially. Mm-hmm. And anything that is malignant means it has the potential to break out of where it grows and goes to the different parts of the body that can eventually kill you. It becomes cancer or malignancy. So tumors are, you can go in, remove the tumor without much consequences unless the size of the tumor has increased and causing adjacent organs to be compromised. But for cancer, not only you have to remove the cancer, but you have to remove some normal tissue around it. Mm-hmm. And then in head and neck, you need to make sure that you reconstruct appropriately. And then when the cancer is diagnosed and the pathology report comes back, we sit together as a team to see if they require additional radiation therapy. Do they need to go through chemotherapy or immunotherapy? Mm-hmm. And then they go through the treatment. So it's a slow, careful, stepwise approach to make sure the cancer is completely out.
So I suppose it depends on the type of cells that you find.
That's exactly right. So each of the cancers are different.
Okay.
Yeah.
And so what I'm getting to, doctor, is that I know that, as we mentioned, there are tumors, but there are also the other type of cancers that are that spread, that you mentioned melanomas and everything like that. Are there any other similar type of cancers that you oversee?
So majority of the head and neck cancers are what we call squamous cell carcinoma. Those are the cancers arise from the skin cells or the lining cells of the head and neck.
Okay.
And those are the one has the capacity to grow, and if it reaches a certain size, it can break off and go to the neck and get lodged in the lymph nodes, that then the lymph nodes get enlarged. And if we don't take care of it, then it still travels to the lung, bone, brain, elsewhere.
Mm-hmm.
So there is a stepwise progression from what started as something small.
Okay, so it sounds like the squamous cell cancers are very ominous,
Yeah.
especially if not caught quickly.
That's right.
Okay, so now we know the different type of cancers that exist in this area. What do you think some of the causes are that lead to these cancers?
So over the last several decades, we have enough information and proof that majority of the head and neck cancers come from overuse of tobacco and alcohol. But that has been slowly decreasing.
Oh, that's
over the last
interesting.
year.
And why do you think that?
It's because people are not using tobacco and alcohol as it was before. So
Okay.
the public health campaign has worked.
Mm-hmm.
However, there is a new cancer on the rise in head and neck of the tonsil and base of tongue, or the back of the tongue, is caused by a virus called HPV, human papilloma virus,
Right.
that you acquire through mucosal contact. Mucosa is any of the lining tissues of our cavities.
Okay.
Usually it is transmitted as a sexually transmitted disease that can hide in your system for a decade or more and then show up as cancer. This is also a squamous cell carcinoma,
Okay.
but a subtype.
Wow. I think you're surprising me, and I think you're surprising the audience to hear that the new type of head and neck cancers are HPV related or caused by HPV. Frankly, I always thought that HPV was in the genital area of the of our bodies, and you're saying because of different types of sexual behaviors, it is being transmitted up into the oral cavities.
That's exactly right. HPV we all know because cervical cancers in females was caused by HPV. However, the new statistics says that by 2020, HPV-related oropharyngeal cancer will exceed the number of cancer cases compared to the cervical cancer. So it is an
Wow.
epidemic, and
Wow.
that needs attention.
Wow, that really is a frightening type of thing, and I'm sure that type of cancer, it can be devastating because it's in the areas where you talk. You said it's in the voice and swallow.
Yeah, that's for
So
sure.
even if treated properly, you can have long-lasting effects, as I said in my introduction.
Right, so that's the whole point of trying to catch this early. Then we can give almost their normal function back without any residual effect.
Mm-hmm.
But the longer people wait to get diagnosed and get treated, then it will affect their speech and swallowing.
Mm-hmm.
But we are able to minimize those effects.
Okay, so what are some of the symptoms that people should look for so that they can go and get treatment appropriately?
One of the simple ways that I tell my patients and when I'm educating lay public is that anytime you have a one-sided symptom in the head and neck, pay attention to it.
You mean either on the right side or the left
only
side?
on the left side.
Okay,
exactly.
that's what you mean by one-sided.
One-sided, that's
Okay.
exactly right. So if that lasts over 3 to 4 weeks, then we need to pay attention. Some of the typical presenting symptoms for patients are one-sided throat pain, one-sided lump, difficulty with swallowing, or pain with swallowing, or speech changes, etc. So you need to pay attention to what's happening and see if it gets better without any major intervention.
Mm-hmm.
But if you are over 50 and you have unilateral one-sided symptoms, that's been there for 3 to 4 weeks, you should definitely see your primary care doctor, who will then refer you to an otolaryngologist, head and neck surgeon.
Going back to HPV, and you mentioned that it's fast growing, is there a definition of who gets it, or is it age related, or is it does females versus males have more of a predilection for this? I mean, who is getting this more frequently?
Right. So HPV is obviously people who are sexually active are the one who gets it. You are exposed to it when somebody becomes sexually active early in their life. So that's some of the reasons that we propose vaccinations to kids before they are sexually active to prevent some of these cancers. But then in their late 30s, 40s, 50s or 60s, then patients present with these symptoms. And then once we diagnose it, it ends up being HPV related. This tends to be more of a male predominant disease, at least for now. Females also get it, but it tends to be more male. It tends to be more affluent or people who are in the higher socioeconomic status tend to get it, compared to the head and neck cancers that used to come from smoking and tobacco tend to be on the other end of the spectrum. And we don't know why the sex difference, but that men tend to get it more. And at least statistics shows that anybody with 20 or more oral sex partners are at extremely high risk for getting this.
Okay.
Yeah.
Okay, fine. So getting back to the symptoms, one-sided, difficulty swallowing, a change in your voice.
Yeah.
What if you think you have tonsillitis or something like that? Would that be?
Of course.
You never had your tonsils out and it's red and it feels ugly back there?
Right. So that's why I give 3 to 4 weeks. If regular tonsillitis, regular laryngitis, all will subside within that period. That doesn't last. You know, a regular tonsillitis will not last over 4 weeks.
Okay.
So.
Right. And also you mentioned tongue and mouth and everything like that. Does it affect your palate? Does it affect your tongue, your teeth, your lips? What else would you notice?
So different parts of the head and neck get different types of cancer. But they're all squamous cell carcinoma. The lips tend to be people who have a lot of sun exposure, but also people who smoke tend to get that. Same thing with the gingiva or the gums and the teeth, in between the teeth area, are people who use chewing tobacco.
Oh, yes.
Tend to get that.
I think of baseball players and chewing
That's
tobacco.
exactly right.
Do they have a higher tendency for that?
You know, I don't know if there is any statistics on players who use it, but we know that as a population, people who chew tobacco tend to get cancers of the inside of the mouth and the gum area.
Or people who chew various type of, let's say, beans or something like that in other populations of the world as well. Right.
So, there's something called the betel nut and areca areca nut and betel leaf are chewing in Southeast Asia is very predominant, and they tend to have higher risk and higher incidence of head and neck cancer, especially of the oral cavity from that.
Okay.
Yes.
So, doctor, if somebody now has a symptom and they've come to an otolaryngologist for diagnosis, and you've taken their history and done some testing on that, how do you determine what sort of treatment options that they should be following if they have been diagnosed with head and neck cancer? And what are some of the treatment options that you have?
Absolutely. Like you mentioned, when a patient comes in, the first thing we do is take a thorough history to make sure the risk factors for the patient. And then we do an exam, do a physical exam. Sometimes I use an endoscopy in the clinic to see areas that I couldn't see from outside, like inside the nose, back of the throat, voice box, etc. Once we have a location of the lesion, we do a biopsy. Then we'll get the tissue diagnosis. Then we get CT scans, MRI, or PET scan to see if it is local or has it metastasized anywhere else. Then we'll make a decision about the treatment options. So the curative treatment for head and neck cancer is only 2 types, which is surgery or radiation.
Okay.
So if early stage cancer, if you can do surgery, literally that is the quickest way to cure a patient with head and neck cancer. By the time they wake up from the operating room table, the cancer is gone.
Right.
It's just a matter of recovery and getting back to,
Right.
their normal.
And now
life.
I can understand how that works with the tumor, but does that work with the squamous cell as well?
Right, exactly. So, most of the skin cancers are treated with surgery. Most of the early stage of most of the head and neck cancers are treated with surgery.
Okay.
And
Okay.
then we'll go into, as it get advanced, then you add radiation therapy. Some of the cancers you can also treat with radiation alone, but it's a prolonged process compared to surgery, which is much quicker and faster.
Right.
And depending on the stage of the cancer, then we add chemotherapy to all of this.
Right. Okay, so surgery is indicated almost always in this case, right?
Unless it's very advanced, where we said,
If it's metastasized,
then we don't do surgery.
You can't do surgery.
That's right. Once it's metastasized to the rest of the body, then the surgery is very rarely used unless we have to help them in terms of breathing and swallowing, etc. But yes, very rarely.
Okay.
Is that.
And you mentioned melanoma also. Now, when I think of melanomas, I think of going to the dermatologist, and I don't think of melanomas as in the head and neck region. I think of it maybe on the top of my head, or a gentleman who's gone golfing or playing tennis, and they're exposed to the sun all the time.
Right.
Is that in your field as well?
Right. So, anybody with any skin lesions that is concerning, they should always go to their dermatologist, who will examine them, make the diagnosis by biopsy of what it is. From a head and neck cancer perspective, I do the surgery of resection and reconstructing it.
Okay.
And sometimes when you have a big enough squamous cell carcinoma or melanoma, you need to do a parotidectomy, which is the salivary gland in the face. That is done by head and neck surgeon. If you need to do what we call a neck dissection, removal of the lymph nodes, it's also done by head and neck surgeon. So that's the reason. Once it becomes more advanced, head and neck surgeon will be the person that you need to go to.
Okay. Doctor, you mentioned that also that your department has transoral robotic surgery.
Right.
And that is very hard to say, and it's kind of hard to understand. So can you tell us what this is? Is this something new that's come down the line?
Yes. So in probably 20 or 30 years ago, if you get head and neck cancer in the back of the tongue or your voice box, you had to go through massive open surgery to get to it, and long recovery, 2 to 3 weeks in the hospital ICU. You need a tracheostomy, you need a peg tube, etc., to get through the process. Then came what we call transoral laser microsurgery. That can we use our natural orifice, which is our mouth, and use lasers and endoscopes to do surgery without doing big surgery. Then we developed this robotic surgery, which has been already in use for prostate cancer and other surgeries, the same Da Vinci robot that we use for the back of the tongue, tonsil, and the voice box area cancers. So it is new. We got FDA approval in 2009. It was pioneered in University of Pennsylvania. That's the reason that I went there for my fellowship.
Oh, I see.
And now it is commonly adopted for this oropharyngeal cancer that is increasing in number with HPV. And early stages, you can do surgery alone and be cured, or surgery plus some reduced radiation. There's some good clinical trials going on to see how robot is making a difference in people's life.
The scene is very hard to imagine that that the surgery is being performed by mechanical device.
Right.
You're not even in front of the patient. You, I think, are behind a console.
Yes.
And you're manipulating the arms of the robot, right?
Yeah.
And with a huge magnified screen.
That's right. Yeah.
So tell us how that works. I mean, honestly, how can you be way over there and work on this? That's just like unbelievable.
Right. Thousands of years of surgical norm has been changed. You know, surgeon was always next to the patient. If you look at ancient Indian surgical textbooks or Egyptian textbook, you know, the surgeon was always next to the patient doing the surgery.
Right.
But the robotic surgery did was they separated the surgeon and the patient, essentially. The surgeon is looking through a 3D camera.
Okay.
And so there's a surgeon console that is a 3D camera. Then the patient has the patient console there with the instruments. So surgeon looks through the 3D camera with manipulators in their hand to move the cutting device and grabbing device that is done everything through the mouth with a big magnification that is helpful to the surgeon to see the surgical area clearly.
Well, that's like totally miraculous. Now, not to scare our audience, this is done when the patient is asleep in general anesthesia, correct?
Absolutely, yes.
And of course, their head has to be totally immobilized, otherwise it can't be precise.
Right.
So somebody is immobilized and their mouth has to be wide open. What if somebody can't open their mouth that much? Do you still do it, or do you pass on that patient?
Right. So, you know, that's exactly what you said. It's a patient choice. So that's one of the reasons for the history physical examination to see if the patient is suitable for these new types of surgery. If they cannot open their mouth, or we cannot expose the tumor appropriately, we will not be able to do it. Mm-hmm. Then we have to consider open surgery, or do we go through radiation chemotherapy?
Okay. So the advantages of robotic surgery are?
It is minimally invasive. You know, it enlarges the vision, the surgical field, and be able to precisely remove the cancer, quicker recovery, less pain, and quickly going back to your life. Instead of being in the hospital for 3 weeks, literally 3 days or less you spend in the hospital.
Wow, this is totally amazing. So, Dr. Thomas, I want to thank you so much for explaining to us about the different types of head and neck cancer and showing us exactly where that is, and now all these new treatment options. So thank you so much for joining us on 30 Medical Minutes, and thank you so much for joining us on 30 Medical Minutes and learning about head and neck cancers.